All right, we're going to go ahead and get started. I know some people are still trickling in from the break time, but I won't miss anything. Again, I'm your moderator, Brian Irons. I'm an associate professor with the Texas Tech School of Pharmacy, and I'm also the head of the Division of Ambulatory Care with the School of Pharmacy. I got my bachelor's and my PharmD in pharmacy at the University of Wisconsin-Madison. I did a PGY1 residency in St. Paul, Minnesota, and then go anywhere for a year, even Texas, for my PGY2 residency with Texas Tech University, and have been there ever since. So that is the gist of me. I'm going to try to get you guys out of here for lunch if we can. I have a lot to talk about. I have the dubious honor of trying to cover everything in endocrinology and metabolic syndromes in 90 minutes. And that's a daunting task. But we'll see how it goes. I have no conflicts of interest. We can't hit everything. I have a very detailed chapter there for you. We're going to hit the highlights because we have a lot of different disease states to hit. But we're going to hit the basics in thyroid disorders, both hypo and hyper, as well as thyroid storm. We're going to talk about adrenal disorders, primarily just on Cushing syndrome and hyperaldosteronism. Even though there's a host of other conditions, those are probably the main two, and hence why we're going to talk about them today. I'm actually going to skip the section in your chapter on pituitary disorders, simply from the rarity of most of the types of disorders in there, but again, fairly good detail in your handout. And you're going to see hyperprolactinemia, necessarily just some medications and the like, but for the most part, pretty rare diseases. We're going to talk about obesity because there's been a lot of changes over the last 10 months in medications and their use in the treatment of obesity. We're going to talk about polycystic ovary syndrome, or PCOS. In brief, even though it's really more affecting the women's health care, which we're going to be talking about more this afternoon, but it is an endocrinology disorder. And we're going to spend a considerable amount of our time on diabetes management because you're going to see more diabetes from an endocrinology perspective than any of the other conditions combined times 10, especially in this country. There's been new updates in the therapeutic management of hyperglycemia by the ADA in 2012. The new medications. Some new medications came out literally this last few weeks. And so we're going to hit the highlights in diabetes management and spend a considerable amount of our time on that. But I can't ignore the other things, but we're going to hit the highlights of thyroid and the like. All right. For those of you who like guidelines and want to stay abreast of things, there's been updates in the therapeutics of both hyper and hypothyroidism within the last 2 years. I've given you the reference here in the slide, as well in your reference section in your handout. Good material to go when you need further answers beyond the chapter. When we talk about hyperthyroidism today, we're going to be primarily talking about Graves' disease. Yeah, there are a lot of other conditions associated with hyperthyroidism that can occur, but the more common one you're going to see is the autoimmune disorder, where the body actually produces antibodies that mimic thyroid-stimulating hormone that's usually secreted from the pituitary gland to stimulate the thyroid gland to put out T3 and T4. We're going to briefly hit again on thyroid storm. And the treatment of hypothyroidism, in this case Hashimoto's disease. All right, you can spend a lot of time looking at various laboratory measurements for thyroid disease, but the free T4 and the TSH really tell most of the story. Look at the free T4 first. If it's low, well, it's probably hypothyroidism. If it's high, it's hyperthyroidism. Not rocket science there. But the TSH can also help you figure things out. In hyperthyroidism, the TSH is usually going to be low. In hypothyroidism, the TSH is going to be high. Again, because there's that lack of negative feedback syndrome. In this case, Hashimoto's, where usually T3 and T4 will produce negative feedback onto the pituitary gland, and they'll stop secreting TSH. In this case, that negative feedback is broken, and you still have a lot of input of TSH, despite the fact that you actually have a low free T4. Now you can get carried away and you can start looking at autoantibodies and the like, radioactive iodine uptake. Those help in the overall initial diagnosis. But when we're looking at therapeutics and managing hyper and hypo, the free T4 and the TSH tell us a world of the story. Given, those classic signs and symptoms of hyperthyroid and hypothyroidism have not changed since you went to school. I always talk to the medical residents and pharmacy residents and my students that, think of the thyroid gland as, your thermostat. If it's revved up, everything is increased. Your metabolism is increased. You usually have an increased appetite. You have weight loss because everything is moving faster. You may or may not have goiter. Patients complain of intolerance to heat, having fine hair. In worst case scenarios, because everything is revved up, including the heart, you can have tachycardia and palpitations. Patients may feel anxious or nervous. You get that sweaty skin and moist skin. And you get that classic in the Hashimoto's, the classic sign and symptoms of those bulging eyes that you remember those pictures of in PharmD school. Hypo is the exact opposite. It's the yin and the yang of thyroid disorders. Instead of weight loss, there's weight gain. Instead of moist skin, there's dry skin. Heat intolerance, now we have cold intolerance. They feel more run down and then anxious. It can actually be misdiagnosed with depression in some patients. Instead of tachycardia, we have bradycardia, slow reflexes, and coarse skin and hair. What are our goals with respect to the treatment, whether it's hyper or hypo? Well, it's to improve the quality of life and to minimize and eliminate symptoms. You can say that practically about any disease. And hopefully to minimize long-term damage to the body, whether it's hyper and osteoporosis and the like, and hypo to the heart. And hopefully then be able to normalize the free T4 and the TSH. For all intents and purposes, that's what we're trying to do when we're trying to treat Hashimoto's or Graves'. All right, our first case. We have a patient diagnosed with Hashimoto's. Again, hypothyroidism. The TSH is elevated. The free T4 is low, given the in parentheses here, the normal units. The patient complains of dry skin and feeling run down. What's the best drug for initial treatment in this patient? Is it levothyroxine? Is it liothyronine? Is it desiccated thyroid? Or methimazole? You guys are just kind of tired of the audience response system, aren't you? All right, we're going to come back to that. Now, patient case 2, a patient with Graves' disease in this case. Does not want to undergo ablative therapy, which is usually the treatment of choice for Graves' disease. The TSH is quite low, the free T4 is quite high, and they complain of feeling warm and anxious all the time. What is the most appropriate initial treatment for this patient? Is it Lugol's, PTU or propylthiouracil, a beta blocker such as atenolol, or methimazole? Seeing some yellow, seeing a little bit of red, or blue, excuse me. All right, good. I'll come back to these here in just a moment. All right, focus first on Graves' disease and then its treatment. Again, radioactive iodine ablative therapy is the treatment of choice. But not everybody is a candidate for that, or not everybody wants to go through that. So usually we're going to reserve pharmacotherapy for patients either awaiting surgery, if it's an adenoma, or if they're awaiting ablative therapy. This helps to kind of deplete the stored hormones that are in the body. Because usually ablative therapy will cause a thyroiditis, and you can leach out stored hormone. If the patient's not a surgical candidate or ablative candidate, or actually just completely refuses, like the case we just saw, or if they've actually undergone ablative therapy or surgery and they're still having elevated thyroid levels of free T4. The treatments haven't changed since you went to pharmacy school. It's basically still PTU and methimazole. These medications work by inhibiting the synthesis of T3 and T4. Remember, most things that are secreted as T4, they get converted in the periphery to T3, which is the most active compound. Methimazole is the preferred agent based on the current guidelines. It's not based on efficacy. The efficacy of methimazole and PTU is about the same. One is not any better than the other. Now, on a milligram per milligram basis, from a dosing strategy, methimazole is 10 times more potent, but it's not necessarily any better. But it's based on the side effect profile we'll talk about here in just a moment on the next slide. And the reason why we don't use these medications as initial therapy for most patients is because the remission rate is extremely low. It can be anywhere between 40 and 50% after 1 or 2 years of therapy. It may take weeks for some patients to actually see some symptomatic relief, and it may take months to actually see a maximum relief in their symptoms. Again, the reason why methimazole is considered the drug of choice now is because PTU has been associated with hepatotoxicity. And the most current guidelines recommend if you are going to use the agent, is to obtain baseline LFTs. Both agents can cause transient leukopenia, potentially for rash, fever, arthralgias. Bless you. In very rare cases, it can cause agranulocytosis, and the new recommendations are to actually obtain a baseline CBC. You don't have to get serial CBCs on the medications, but you should get a baseline one. And then you have a serious infection, you can get a different one. All right. Beta blockers are commonly used as well, but they're really there for symptomatic relief. Once you're actually on a medication to try to inhibit the synthesis of T3 and T4, right, and they don't control the symptoms, that's when we're kind of reaching for beta blockers. The most studied and commonly used ones are nadolol and propranolol. Again, for symptomatic improvement, all that tachycardia, the anxiousness, tremor that some patients may experience, they're good for that, but they're not good for actually overall treatment of the disorder, because they're not going to do that much for the thyroid hormones themselves. New recommendations are to recommend beta blockers in elderly patients, symptomatic patients, or those with heart rates greater than 90. Those are the new updated recommendations within the last year or two. Iodines can be used. These don't block the synthesis of T3 and T4. They just simply help block their release. And they should only be used in the short term, over 1 to 2 weeks at most. Because after a while they stop working, the gland will eventually start to leach out hormone regardless. But they're good before surgery to help reduce the vascularity, go into the gland itself prior to surgery. All right, so patient case 2, we have a case of Graves' disease again. The elevated free T4, low TSH with symptoms. The most appropriate initial treatment option at this point would be D, the methimazole. Again, not any better than propylthiouracil, but less hepatotoxicity. Moving to hypothyroidism. Again, all this is in your handout. We bounce around a little bit, but beware. The drug of choice, based on the American Thyroid Association, is synthetic T4. Recertification. Based on its overall ADR profile compared to the other agents that you could use are still available, and some patients are still taking them. Based on its overall potency, its overall antigenicity profile, and its overall cost, it's really the treatment of choice. They would recommend, in some cases, some guidelines would recommend brand name only, and don't switch between brand names and generics. And I got some information on bioequivalence and why it should or should not actually be AB rated with anything in your handout. The new recommendations on treatment are not to really start low and go slow unless patients are older, but the average patient, if they're younger, less than 50, you can simply start out on a weight-based dosing strategy of 1.6 micrograms per kilogram per day, based on the ideal body weight. For patients who are 50 to 60 years of age, you might want to start them out a little lower and just start out at 50. These are the new recommendations last year. And in those patients with a history of cardiovascular disease, because there's a potential for overshooting and causing problems with the heart, that you want to start at much lower doses for those patients just to see their effect and their symptomatic improvement. The overall half-life of levothyroxine is about 7 days, so you're going to not really hit steady state for about 5 or 6 weeks with the medication. If you overshoot, you're going to start seeing those signs and symptoms of hyperthyroidism. It's quite easy to overshoot in some patients. Hence why a lot of physicians will start much lower doses than that 1.6 micrograms per kg per day. But the worst case scenario can actually cause a full-blown MI or angina and the increased risk for bone fractures as well, long term. All right, so back to that patient case then with Hashimoto's. What is the best initial treatment of choice against levothyroxine? You can still get synthetic T3. You can still get desiccated thyroid, but they're no longer recommended. But there's a lot of gurus out there that say, well, a combination of T3 and T4 is better from symptomatic improvement and yada yada. Most studies are extremely small and mostly unnecessary in the average patient. There's a lot of people that use it more as an art than a science. But again, synthetic T4 is really the treatment of choice. Pretty easy. So A. Worst case scenario with hyperthyroidism. Again, there's a little bit of information on subclinical hyper and hypothyroidism in your handout. I just put it in there for completeness sake. We're not going to cover it here today. But in the worst case scenario of hyperthyroidism is thyroid storm, commonly caused by either a significant infection or trauma in some patients. They can be very, very life-threatening, hence it's a medical emergency. Patients may present anywhere between just simple delirium to a full-blown coma. And based on the rather general signs and symptoms, unless you actually get a free T4, you're having no idea the patient's actually in thyroid storm. But this is a multifactorial approach now to care in the inpatient setting. The PTU is the recommended medication. They're giving you the loading doses and the scheduled doses here for PTU. After it's been initiated, they recommend iodine treatment as well to help, again, prevent any more T3 and T4 to actually be leached out of the thyroid if you can. Esmolol, propranolol, commonly used for the symptomatic improvement of these patients, again, so we can use beta blockers. You want to avoid NSAIDs for the fever. They recommend APAP simply because of protein binding with NSAIDs can actually displace bound T4 and T3. And corticosteroids are recommended to decrease inflammation as well. So multifactorial, very simple one slide for thyroid storm that can be a very, very devastating condition. That is everything on thyroid disorders we're actually going to cover. Again, we're going to skip pituitary and we're going to move right down to adrenal disorders, which are still fairly uncommon, at least Cushing's and the like, they're going to see, but you're going to probably see more of this than you actually will with pituitary disorders. Our treatment goals for adrenal is really to help, again, reduce morbidity and mortality, same it is with any disease, eliminate the cause if you know what it is, such as excessive use of oral corticosteroids, hopefully reverse the clinical features, hopefully normalize biochemical changes, and hopefully, if we can, put the patient in long-term remittance. All right, so patient case 4 on page 349. You have a patient with consistently elevated blood pressures. I see this all the time in my clinic, in my hypertension clinic. Patient's already taken 2 antihypertensives, complaints of headache, thirst, fatigue. They get a urine-free cortisol level, it's at 45, which is normal, and they get an elevated plasma aldosterone or renin, and it's elevated at 125. What is the following is the most likely cause of this patient's elevated blood pressure? Is it Cushing's? Is it Addison's? Is it hyperprolactinemia or hyperaldosteronism? It's a lot of yellow out there. Good, good. Pretty easy question. Just how it's phrased. For Cushing's syndrome, again, we're talking about an adenoma in the case of Cushing's disease, which part of Cushing's syndrome is an ACTH dependent, where the pituitary gland, you can consider this a pituitary disorder as well as an adrenal disorder, but the pituitary gland is putting out way too much ACTH. It's stimulating the adrenal gland to continue to push out more corticosteroids. And when you think about it, think about those signs and symptoms. If you put somebody on oral glucocorticoid therapy long term, what are those nasty side effects they can have? They can have hypertension, osteoporosis, fractures. Patients can develop type 2 diabetes or just a minimum of glucose intolerance. They have that moon face that you remember seeing in the pictures from Pharm D school. Facial rounding, the peripheral obesity, the central obesity, fat accumulation. So again, all those signs and symptoms of too much steroids. The treatment of choice, if it's true Cushing's disease, not excessive use of oral corticosteroids itself, the treatment of that is pretty simple. Try to reduce the oral corticosteroids. But for Cushing's, it's surgical resection. We don't try to use pharmacotherapy unless we have to. That's because it's adenoma. It's an adenoma. We want to go out and get the adenoma out of there. But if the patient's not a surgical candidate or awaiting surgery, or have failed even after surgery and they're still symptomatic, that's when medications are warranted. So we've had some changes just since late 2012 too. We have a new medication, pasireotide. I'll talk about that in a minute. But we can either block the synthesis in the adrenal gland of corticosteroids, cortisol itself, or we can try to block the ACTH secretion. So now we have 2 avenues. We only had 1 available this time last year. And we can use other agents then too to treat the signs and symptoms, whether it's try to control the blood pressure, try to control the glucose, try to control the obesity associated with the disorder. Pasireotide has all kinds of potential side effects. I've given some more detail in your handout there, but the endocrinologists I've talked to really don't know the role of therapy of this new agent just yet. It's a fairly rare disorder to begin with, so there's not a lot of data on it. There's really one good study that was out in the New England Journal of Medicine in late 2011 or early 2012. But you got to get ultrasounds of the gallbladder before you take it. You have to use serial blood sugar readings because it can cause hyperglycemia. So there's a lot of side effects associated with the medication. So we just don't know where it fits into therapy just yet. So more commonly, we're going to start to block cortisol production. Ketoconazole is an antifungal, but it also can block cortisol production of the adrenal gland, as well as mitodine, and in worst case scenarios, in the inpatient setting, nitomidate. But if they have high blood pressure, try to control the high blood pressure. If they have high sugars, try to control the sugars. RU486 was actually approved about this time last year for control of Cushing's hyperglycemia. So it actually has multi-uses at this point. That's on Cushing's. Now, hyperaldosteronism. I see this a lot. I run a pharmacist-managed hypertension clinic in a university cardiology group. We see this all the time. Patients are coming in on multiple antihypertensives. The blood pressure is still way elevated, and nobody can seem to figure out why the patient's not responding to even 5 or 6 different antihypertensives. Well, a lot of cases it's actually due to hyperaldosteronism. And primary hyperaldosteronism is usually going to be caused by hyperplasia of the adrenal gland. The worst case scenario is it can actually be an adenoma, but the majority of cases are simply going to be hyperplasia, benign. They may present with headache, certainly high blood pressure, muscle fatigue, weakness, polydipsia, nocturnal polyuria. And in some cases, you don't have to at all, but if you really truly want a diagnosis, you need to get a plasma aldosterone to renin ratio. And if it's significantly elevated, well, it tells you it's hyperaldosteronism. How do we treat it? Well, obviously with an aldosterone antagonist. Spironolactone being the treatment of choice. You could use a eplerenone too. You got to watch with these agents, just like in your hypertension lectures, you have to watch for hyperkalemia, gynecomastia, and GI discomfort in patients. But it's a wonderful class of medications. I've been able to get patients who come in on 6 different antihypertensives off 2 or 3 just by putting the low dose, the medium dose spironolactone on their therapy. Because with the cause of even when they're on ACE inhibitors and ARBs, it doesn't block enough of the aldosterone issue. If you do put them on these medications, you want to monitor obviously electrolytes, again, because they can cause hyperkalemia. Hopefully have some symptomatic relief. Nobody's made a recommendation of actually getting serial plasma aldosterone to renin ratio, but you can just assess for trend in the patient. And certainly you want to monitor for blood pressure. Okay, so in patient case 4, if this was due to Cushing's, their free cortisol level would be elevated. In this case, it's perfectly normal. In this case, it's an elevated aldosterone to renin ratio, and this patient would be D, hyperaldosteronism, which most of you have already picked. All right, that's all about adrenals. Moving right along. We'll talk about obesity because there have been some significant changes in what's available now to treat obesity. And obviously, obesity, for the most part, is considered an epidemic in this country. There's some newer data that suggests maybe we're doing a little bit better, but the overall percentage of the patients out there, or our population in general, who are overweight or obese, is very significant, to say the least. Some of you may call it job security, and it is to a certain extent, but it's something that, from a primary prevention standpoint, we should be really doing a much better job at. All right, there haven't been any really good updated guidelines in obesity in a very long time. The NIH still has a classification scheme that's in your handout and here on the slide. Again, being overweight, you'd have to have a body mass index or BMI of greater than 25 but less than 30. Then they can kind of have different classes or stages of obesity. Consider obesity if you have a BMI at least of 30 or greater. And stage 1 being less than 35, class 2 being 35 to less than 40, and class 3 or complete morbid obesity being 40 or greater. How many of you in your clinic, in inpatient settings or out in a clinic setting, have seen patients who have BMIs greater than 40? That's bad. We need to be doing something about it. The problem is our treatment options outside of diet and exercise are wrought with lots and lots of side effects. So there's no miracle cure here, and all patients want a miracle cure. I wanted a miracle cure for my cholesterol level too. But even after my own diet and exercise, I still need to get out and put on a statin. I wasn't happy about it. It's just the way I was. But now I can eat anything I want. Not true. All right, case 5. We have a patient who recently started locazepam for obesity. They have a BMI of 32, so they are obese. Her weight at this time is at nearly 300 pounds. What is the minimum weight loss expected if we want to continue to take this medication after 12 weeks? In other words, way too many times we're throwing pharmacotherapy at patients, not just for obesity, for other conditions, where they don't see much either symptomatic relief or hit certain outcomes, and yet we continue to use the medication in the patient. So there's cutoffs with the newer medications, and we're not seeing at least a significant effect after 12 weeks of therapy on specific doses that we should just stop the medication, which is a good recommendation. If it ain't working, stop using it. We'll come back to this. Again, diet and exercise is still the cornerstone of therapy. Always has been, always will be, whether you're talking about dyslipidemia, diabetes, or obesity. For those of you a little older, that Meridia was taken off the market a few years ago, secondary to issues with cardiac abnormalities. So then it really left us until last summer with orlistat. This medication, while mildly effective for obesity, has a lot of side effects with it. We're talking oily, loose, greasy stools, flatulence, GI cramping, and the like. Not a lot of side effects people really want. But anytime you start messing with enzymes in the gut, you're usually going to wind up with a lot of GI side effects. In this case, it's trying to inhibit the gastric and pancreatic lipases, and hence the absorption of fat in the gut. And that causes a lot of side effects. It's available both OTC and prescription. The FDA announced some warnings on it about kidney stones last year, as well as liver injury, particularly with the prescription strength dose. So we weren't really sure. It's mildly efficacious, has a lot of side effects, and now we may have some more severe side effects we need to start looking for. Loclacerin, just approved again last summer. We had 2 different agents approved. This is a selective serotonin 2C agonist. You remember fen-phen many years ago, for those of you old enough? Fenfluramine was part of fen-phen. That was relatively a non-selective agonist, but it had all kinds of pulmonary and cardiac abnormalities associated with it, and it was taken off the market. Unfortunately, loclacerin also has lots of side effects, including headache, dizziness, memory disturbances, hypoglycemia in some cases with patients with diabetes taking oral hypoglycemics. It's also quite good for A1C reduction in patients with diabetes. I'm giving you don't memorize any of the weight loss figures here. I just want to show you overall how effective is it. The specific cutoffs based on the FDA's recommendation. If you're going to try to get your medication approved for the treatment of obesity, you have to have X percent of patients have to have at least a 5% weight loss, and X percent have to have at least a 10% weight loss. We're talking less than 50% of patients actually obtain a 5% weight loss. So again, if it ain't working, stop using it. So the recommendation after 12 weeks of therapy on this medication, if you don't have at least a 5% weight loss, you don't need to take it, because all these potential side effects, and we don't know really long-term safety of the medication either, are going to have a major impact. I would not doubt, if I was a betting man and I'm a born loser, I lost $20 last night myself, that this medication is going to get approved for both obesity and type 2 diabetes somewhere down the line in the near future. It's actually quite good at reducing A1Cs in patients with both type 2 diabetes and obesity. All right, this is not necessarily new medications, a new combination of existing products that just got approved within the last 10 months as well. Phentermine and extended-release topiramate. Again, phentermine had been on the market for a long time, a scheduled medication to use in the treatment of obesity, but only in the short term. But they use lower doses in the current formulation here. And topiramate we used to use for epilepsy, we still do. But it also had the side effect of appetite suppression. And so somebody got the idea, well, let's put them both together, put them in lower doses, hopefully reduce the overall side effect profile of the 2 agents combined. It still has a lot of side effects associated with it. I'm not giving you here the efficacy, but about 60% of patients attain greater than 50% or 5% weight loss. The big kicker here is women of childbearing age must have a negative pregnancy test before initiating the medication and monthly thereafter. And because of this issue, it's actually restricted in what pharmacies you can actually try to pick it up in. Like loclacerin, if they don't see at least a 5% weight loss after 12 weeks, in this case at least the higher doses of it. I'm giving you that dosing straight. It's a funky drug to try to dose. I've given you that in your handout. It's too complicated to probably go over and necessity for the BCS exam. But if you don't see at least a 5% weight loss at 12 weeks, stop it. So again, new agents, lots of side effects. The bigger issue, and this is not actually in your handout, I think I developed this the other day, what are the issues? How long do we treat for? You know, I'm on a statin. I'm probably on a statin for life. I have high cholesterol. I couldn't get rid of it with diet and exercise. Well, obesity, you can't really get rid of that. And when they've looked at the trials, if you stay on the medication for a while and stop taking the medication, a lot of the weight comes back. So how long do we treat the patients? We don't know. Our studies haven't gone out for very long. Unfortunately, we don't have any head-to-head comparisons. Everything was looked at against placebo. So and really, what the most nerve-wracking thing is we have no idea on the long-term safety of these medications. So we'll see. So for patient case 5, the patient weighs 300 pounds. We need at least a 5% weight loss. In this case, that would be 15 pounds. So B would be the actual answer, blue. All right, moving along to PCOS. This is really getting more women's care in fertility aspect. The PCOS is one of probably the most common cause of infertility in this country. Why it's not in women's health? They may cover it this afternoon a little bit in your men's and women's health talk. But it's in here because it is an endocrinology disorder. It's about androgen excess. And it's usually thought about by coming about as a result of insulin resistance. And not in lean women as well as overweight women, where the hypersecretion of insulin is causing all kinds of problems, offsetting the natural ratio of LH to FSH. Because there is no great consensus in the overall diagnostic parameters and classification, we're going to avoid it like the plague today. If you're really interested, there's some great review articles out there on it. Other kinds of signs and symptoms outside of dysmenorrhea, including hair growth, acne, and pattern alopecia in women, and usually things that women don't want. You could get an LH to FSH ratio if it's greater than 2. And elevated serum testosterone levels are also associated with the disorder. Excuse me. What do we try to do? Well, if you want to become pregnant, hopefully improve fertility. But not everybody wants to become pregnant. Some people simply want symptomatic relief. Hopefully you can normalize menses and ovulation, reduce those clinical features that we just talked about. And particularly if they're overweight, we want to hopefully reduce their chances of going on and develop type 2 diabetes. What are our options? There's a bunch of different options out there. Again, a lot of good reviews out there for you. Clomiphene is commonly used. It's a selective estrogen receptor modulator. Hopefully help to improve that ratio of LH to FSH. It has a lot of side effects, including vaginal dryness, multiple pregnancies. I'm not talking pregnancy after pregnancy after pregnancy. I'm talking about triplets and quadruplets and the like. And so, you know, that's... You can also use recombinant FSH. Again, it can also cause multiple pregnancies alike, like the Octomom. Metformin is commonly used, usually with clomiphene, but it can be used without it. If you just want symptomatic improvements and fertility is not the main issue and you don't want to become pregnant, Actos has been looked at, spironolactone, estrogen and progesterone combinations have also been looked at. So a lot of different modalities. I'm no expert in women's health care by any means, but a lot of different options out there. Whew, all right. Finally, diabetes. That was everything you need to know about the other disorders. And again, why we're spending more time today on diabetes is because of its overall prevalence. Updates in therapeutic management of type 2 diabetes as of last summer. Updates and recommendations from the American Diabetes Association just this year in January. New medications literally in the last 3 or 4 weeks. And the amount of information, the amount of data we have, the frequency that you're going to see this disorder is why we're going to spend more time on it. In much more detail than what we did on the other disorders. I know that doesn't jive with all of you. I'll get comments that we didn't spend enough time on this. We spent too much time on diabetes. All right, classification scheme hasn't drastically changed since you were in school. Again, we have the underlying ones are the more common classifications we're going to see. Type 1 diabetes. Type 1 diabetes doesn't represent most of patients. It's only about 5 to 10%. Again, the body has completely attacked the pancreas. It's no longer putting out adequate amounts of insulin, and insulin is needed to survive. Type 2 diabetes, which accounts for the vast majority, it is an epidemic in this country and is costing billions and billions of dollars per year. The figure keeps going up astronomically every 5 years. And as we're is going to devastate the Medicare economy here really, really fast, as our baby boomers are now in Medicare and only growing in many different ways. But this is about insulin resistance. The pancreas eventually burns out, stops putting out enough insulin to meet the demands of the body, and then eventually develop hyperglycemia. You can get diabetes during pregnancy. You can get diabetes later in life. You can get diabetes early in life. The epidemic of type 2 diabetes in children is beyond the concept for today. We could spend an hour and a half on why that is and how to treat it. There's been recent updated guidelines in the treatment of diabetes in children as well out there. It can be caused by pancreatitis. It can be drug-induced. There's a whole host of things. But we're going to focus most of our attention today on the treatment of type 1 and type 2, because that's where you're going to commonly see things. All right. Patient case 6. We have an African-American female who's had a significant weight increase primarily due to poor diet and exercise over the last year. Her BMI is 44. Both her sister and her mother have type 2 diabetes, and she has a fasting glucose today of 212. What is the best course of action? Is it to simply right now diagnose her with type 2 diabetes and begin treatment? Is it to diagnose with type 1 diabetes and begin treatment right now? Should we obtain another glucose concentration today, or should we wait another day and get a glucose concentration at another day? Again, this patient is not showing signs or symptoms of hyperglycemia at this time. What do you guys say? I mean, some yellow, mostly yellow, some red here and there. All right. Our high-tech audience response system. We'll come back to that. All right, so we need to be doing a better job of screening. There have been some, particularly for type 2 diabetes, but there's been some updates just this year in the screening for type 1 diabetes I wanted to share with you. If a patient is symptomatic, those hallmark features of hyperglycemia, we're going to screen their blood glucose levels. Again, that polyuria, polyphagia, polydipsia, sudden weight loss. We're going to screen those patients, regardless of age, but this, again, can happen in teens and early adulthood. We don't screen everybody for type 1 diabetes, but if they're a high-risk patient, they have a family member with type 1 diabetes, it's good to screen those patients with a screen for antibodies, autoantibodies to islet cells in the body. If they screen positive, the recommendations now are to simply counsel on the symptoms of hyperglycemia and what the overall risk is for the development of diabetes itself. And you can actually send them into some registries, too, that they're looking at for pre-diabetes. But that's changed this year. That was the update for this year. Screening for gestational diabetes has changed, at least over the last few years. It used to be based on your overall risk. If you were very, very low risk for going on to develop gestational diabetes, you didn't have to get screened. If you were high risk, you got screened right away. Well, the recommendations now are to screen everybody who's pregnant at weeks 24 to 28. And certainly earlier at the first prenatal visit if they have risk factors for type 2 diabetes. And this isn't done with a fasting stick. This is actually done with an oral glucose tolerance test, a very syrupy solution that you take, and getting serial blood glucose levels then over a period of time after you take the syrup. Who do we screen for type 2 diabetes? Anybody over the age of 45 years of age should be screened and screened every 3 years. This hasn't changed in the last few years. If they're overweight, and other risk factors, and this list of risk factors hasn't drastically changed over the last few years. Again, they have some other hallmark issues. They have a history of gestational diabetes, sedentary, have hypertension, high triglycerides and the like. They have prediabetes. You want to really screen these patients much sooner for type 2 diabetes. Didn't work. There we go. Regardless of whether it's type 1 or type 2, the criteria are listed here over the next couple slides, and they're all based on the level of hyperglycemia. If you have a fasting blood glucose level of 126 or greater, that's consistent with diabetes. If you have a random glucose, because not everybody's fasting, if you have a random glucose and the patient is symptomatic, and that random glucose is greater than 200, that's consistent with diabetes. And now, as of at least the last 4 years now, starting in 2010, the recommendations are we can get A1Cs on patients and use it for diagnosis. In this case, if it's 6.5% or greater, it's consistent with diabetes. You could do the oral glucose tolerance test. Again, it's kind of a pain because you have to sit there, get a baseline, take the syrupy, nauseating syrup, and you have to wait around 2 hours to get these serial blood glucose levels. So not practical in the average setting, but it can be used. And these recommendations haven't changed since most of you were in school. If it's greater than 200, that's consistent with diabetes as well. Now, if you get an abnormal reading, if the patient is symptomatic, you can probably diagnose him right away. But the patient's asymptomatic, they would usually recommend to get another reading on another subsequent day, usually the same test. It's not mandatory. You could get an A1C, you could get a fasting, and probably diagnose the patient with type 1 or type 2 diabetes. But that's the recommendations. Okay, so patient case 6, again, African American, high risk ethnicity, morbidly obese. She has first degree relatives with type 2 diabetes, and she has a fasting day of 212. Technically speaking, because she's asymptomatic, D would be the correct answer based on the American Diabetes Association, which I forgot to mention. When I talk about classification schemas, cutoffs, this is all based on the ADA. There are other guidelines out there. Various societies have multiple guidelines out there. But the ADA is probably the most recognized, and hence why we're using that today. I've given you some references for other guidelines in your handouts if you wish. In this particular case, because the patient's asymptomatic, you want to get another, hopefully then fasting glucose on another day. You wouldn't want to get it today. Could you do A, diagnose and treat? It wouldn't necessarily be really wrong because this patient's got diabetes. Got to go with what the guidelines tell you though, not what I do. All right, patient case 7. You have a 56-year-old man, recent diagnosis of type 2 diabetes, no history of cardiovascular disease or other chronic diseases. Which of the following sets of values is the best selection that goes for both sugar, blood pressure, and lipids? Don't you hate when somebody comes up here and gives you a multiple choice question with multiple answers in each question? I do. I probably should hack this question out of there altogether. Is it an A1C of less than 6% with a blood pressure less than 120/80, an LDL of less than 70? Is it an A1C of less than 7%, a BP of less than 140/80, an LDL of less than 100? Lower A1C goal here is 6.5 or less than 8% for C or D. What do you guys think? What do you want? Everybody just wants lunch, I can tell. Smattering here and there. So where's the blood pressure 130/80? All right. Ideally, well, regardless of disease, but here what we really want to do is we want to prevent these patients from going on to develop the microvascular and the macrovascular complications of diabetes. That's our main goal. It's not just about treating sugars, it's to try to minimize the complications of the disorder. The acute complications, and we'll come back to these here at the end of the talk, is to prevent hypoglycemia and what to do when they actually experience it, diabetic ketoacidosis, and non-ketotic syndrome. We'll come back and talk about how to treat the first two of these three. But there's chronic diseases. And we always think about blindness with diabetes. Number one cause of end-stage renal disease in this country is uncontrolled diabetes. The nerve damage, the amputations, foot infections. Macrovascular complications. People aren't dying from retinopathy. They're not dying necessarily from hyperglycemia. They're dying from cardiovascular disease. So if we just focus on sugars, we're really going to miss the boat. All right. What are our goals of therapy then for patients? So this is the same goals whether they have type 1 or type 2 diabetes. The glycemic goals for gestational diabetes are much more strict, and those are also in your chapter. But for type 1 and type 2, the goal fasting or pre-meal plasma glucose level is 70 to 130. Depending on how long you've been a clinical pharmacist, those numbers haven't changed. You have a goal A1C in general of less than 7%. Now that's based on the ADA. Other organizations such as the American Association of Clinical Endocrinology suggest less than 6.5%. But it's also a moving target because now it's a little more about based on the patient. You can get more strict in A1C if the patient's younger, is very motivated, and you think you have a long life ahead of them. We can get more aggressive in the A1C. They don't make a specific recommendation of what that A1C necessarily should be, but you can get more aggressive. Likewise, if they're a much older patient, they have significant other comorbidities, very high risk for, say, hypoglycemia, they've been difficult to treat in the past, you can probably back off on that less than 7%. But in general, it's still less than 7%. How often do we get them? We get them on patients who are uncontrolled every 3 months because it gives us that overall average glucose about hypoglycemia over the last 2 to 3 months. We get them every 6 months if they're controlled. You can get postprandial. I usually only do this in my type 1 patients. I don't do it very commonly with my type 2s. You can, but we have specific goals for 1 to 2 hours after a meal of glucose readings less than 180. Again, I talked about the gestational. I'll be much more aggressive. That's the nitty-gritty of what we're shooting for from a glycemic standpoint. But again, if you just focus on hyperglycemia, you're going to miss the boat. Blood pressure. Per the ADA this January, they changed some recommendations. We haven't seen what the GNC late will behold later this summer, but I bet they are on board with this one as well. Right now, the goals from the American Diabetes Association in general is less than 140 over 80, not 130 over 80. But they do suggest that if the patient's younger, to reduce the overall risk of going on to develop kidney damage, that you can still use the goal of less than 130 over 80. If the patient's a high risk for stroke, you can also use the 130 over 80. Well, they're not very definitive of who those patients are. It's a pretty general statement. LDL should be less than 100. If they have a history of cardiovascular disease in addition to diabetes, you could use the option of less than 70, just like in your cardiovascular handouts. Triglycerides should be less than 150. HDL should be greater than 40 in men and greater than 50 in women. So not too much changes there. All right. If I improve your sugars, am I improving macrovascular complications? Yes and no. Depends on what study you look at and how you interpret it. Overall, prospective studies looking at the treatment of hypoglycemia have not shown a significant reduction in cardiovascular disease. But we have seen reductions in going on to develop retinopathy or attenuating this progression. The same with damage to the nerves and damage to the kidneys. Cholesterol helps reduce your overall risk for the macrovascular complications, particularly MI. Blood pressure helps reduce your risk for both. So getting aggressive on the blood pressure is not necessarily a bad thing, depending on how you interpret the studies. But in essence, you can help reduce their overall risk for retinopathy with both blood pressure and sugar control. And you can reduce your risk for MI with blood pressure control and lipid management. And at the end of the day, that's what we're really doing. Don't just focus on the sugars. You're going to miss it. All right, for this patient with the complex little 15 different scenarios, B, technically speaking, is A1C less than 7%, blood pressure less than 140 over 80, and LDL less than 100 are our treatment goals in general. All right. Let's focus then on what we have. When I went to school, it wasn't that long ago, but when I went to pharmacy school, we had, sulfonylureas, we had NPH, we had regular insulin, we had this new kid on the block that just got approved called glucophage. Lispro came along when I was in pharmacy school, TZDs came along right after that. We have a lot of different medications now to treat type 2 diabetes. The problem is, how do we select specific agents for a specific patient is very difficult. It's more of an art than a science. If you think about it, we have agents that help work at absorption of sugars in the gut. We have agents that help, again, put pancreatic output of insulin better. In addition to sulfonylureas, we have a host of different classes of medications now that improve pancreatic output of insulin or decrease glucagon production in the pancreas. We have medications that help shut off gluconeogenesis in the liver, which is oddly continuing to occur in patients with type 2 diabetes for various reasons. It's bad. We have medications that help kind of slow down gastric emptying. We have medications that help promote satiety. We have medications that help improve insulin sensitivity in the muscles and the adipose tissue. And now, as of this month, we have medications that reduce glucose absorption in the kidneys. So a whole host of things since just the old NPH, regular insulin, and sulfonylurea era. We'll come into each one of these here. All right. Don't ask me why I put sulfonylureas in your handout before metformin. Metformin is the drug of choice for the initial treatment of hyperglycemia, unless there's contraindications in patients with type 2 diabetes. That's pretty consistent amongst all guidelines out there. Side effects, most of the patients are going to need to be put on at least 2,000 milligrams a day, the usual maximum clinical dose. But we don't start them at that because they're not going to like it. A lot of GI side effects, so we start a little bit lower, let them get used to it from a gastrointestinal standpoint, with most patients still going to be needing 2,000 milligrams a day. Lactic acidosis we always think of with metformin, but it's an extremely rare side effect. It's a very devastating side effect if you have it. It's got about a 50% mortality rate. But it's very, very rare. And usually the patients that get it shouldn't have been on the medication in the first place. Uncommon events such as hypoglycemia can occur, but for the most part, very, very well tolerated. The reason why it's the drug of choice, it's very effective in how it reduces A1C. It's very well tolerated in the patients who should be on it. It's very cost effective because it's very cheap. In patients who are obese, it may actually reduce your risk for cardiovascular disease. So a host of different issues. And we can practically use any other medication on top of metformin. Everybody wants to get their drug now taken with metformin when they try to get it approved with these new medications. Some precautions. For a while there, everybody said, I can't use it in patients with heart failure. You can use metformin in patients with heart failure, as long as it's not very severe heart failure and they're not having frequent exacerbations. I avoid it like the plague in patients who have significant heart failure and frequent exacerbations. If they have a potential risk for hypoxic state, older patients with significant renal impairment, older patients, you may want to at least be cautious with it if they are older, simply because it's very difficult to attain creatinine function in some patients who are older. They may have a very normal creatinine in the lab, but they may actually have poor creatinine clearance. Again, you've got to remember, metformin is excreted nearly unchanged in the urine. It's not metabolized. What are specific contraindications? Didn't change since you were in school. These are the same cutoffs they used in the phase 3 trials way back in the late 80s. Serum creatinine of 1.4 or greater in women, 1.5 or greater in men. You'll see some people have recommendations based on creatinine clearance, but there's more than one or two out there. For those folks of you working in an inpatient setting, you'd want to hold metformin if they're going to undergo any kind of procedure that's going to use iodinated contrast dye, because it can be very nephrotoxic. And usually would hold it and for at least 48 hours, obtain another serum creatinine to make sure that there was no nephrotoxicity with the dye before you reinitiate the metformin. And certainly any procedure, surgical procedure that's considered more than just simply minor, the recommendations are also to hold it before surgeries for those, because you don't want to go to hypoxic, reduce kidney blood flow. Sulfonylureas, great medications to reduce hyperglycemia. You know, they get a big bang for your buck in A1C reduction. They're very cheap. They're all generic at this point. The problem with them is they have a significant risk for hypoglycemia and weight gain. We continue to tell our patients, you got to lose weight, got to lose weight, got to lose weight. Then you put them on a medication that makes their weight go up. Other side effects are less that. But again, the guidelines now that are reflective of 2012 and continuing in 2013 are, you know, if the patients have very, very high risk for hypoglycemia, or they've had problems with it in the past, that you might want to consider avoiding the medication. If the patient is going to have significant problems with increasing their weight, you'd probably want to avoid the medication as well. But very cheap, very effective, and those of you guys who work in the VA are kind of screwed and you kind of have to use it first. All right. Meglitinides. A bunch of VA people out there, I see. All right. Meglitinides work very similarly to the sulfonylureas by putting out more insulin for the pancreas. They're kind of glucose dependent. You know, sulfonylurea will still work if you have a blood glucose reading of 60 milligrams per deciliter. Meglitinides kind of shut off after a while. And so they really don't work unless you have significantly elevated blood sugars, which is kind of nice. And they're they're more focused on hypoglycemia after a meal than they are on fastings. They can still have an effect on fastings, but they have a better target at postprandial hyperglycemia. And I love these agents in some patients, so I try to use pseudo-basal bolus with some insulin, some PO medications that I know aren't good candidates for basal bolus therapy, which we'll talk about here in more detail in a minute with multiple injections of insulin. They can cause weight gain as well. But good medications. Repaglinide is probably better than metaglinide from clinical trial data. But again, we're trying to get into what is the risk for hypoglycemia? Is weight an issue? Is there a postprandial issue or a fasting issue or both when we're trying to select agents? We'll come back to that. And there's a good table at the end of your chapter on these various agents, on the kind of the pros and cons of the different classes of medications. Yeah, my clicker ain't working. There we go. TZDs. Wonderful medications to control hyperglycemia. I mean, Insulin resistance, you're not hypertension resistant, but insulin resistance is the root of all evil in type 2 diabetes. It's how everything starts. It's the egg before the chicken or the chicken before the egg. Insulin resistance. And these medications do a wonderful job of improving your sensitivity to insulin. It's almost like gene therapy in a pill, depending on how the way you look at it. Very effective in reducing A1Cs. Now have gone generic with the pioglitazone. Well tolerated from a monotherapy standpoint and the risk for hypoglycemia. The problem is we're getting more and more data. Seems like every week or every month something comes out about how bad these medications are for you. Do they still have a role? Yes, but it's getting limited. Remember, Avandia, rosiglitazone got taken off the market. Well, didn't really get taken off the market. For all intents and purposes, though, it's extremely tough to get. And there's really no role for it in the treatment of type 2 diabetes anymore. So really, when we're talking about pioglitazone as really the only agent right now that's really able to use in the treatment of type 2 diabetes. But it can cause problems. If you have significant heart failure, you probably shouldn't be on the medication. It may cause bladder cancer. It actually got pulled from the European Union within the last year because of this potential risk for bladder cancer. Every patient I had on it, I talked to them about this over the last year and say, you know, there's a potential risk. Here's the other options. It's working for you. That's why you're on it right now. It's working great for you. It has been for a while, but there are potential other risks associated with it. What do you want to do? Including fracture risk in both men and women. Every patient I've had on it wanted to get off of it after I've told them potential risk. Small, but still there. But a very effective medication. And then I have to scramble. After I take them off it, their sugars go through the roof, and I figure out what the heck to do with them. It takes me about 3 to 4 months just to get them back under control. They are contraindicated, again, if you have class 3 or class 4 heart failure or significant liver impairment. You don't have to get serial LFTs the way we had to when they were first marketed, which is kind of nice. All right. Glucosidase inhibitors, or glucosidase inhibitors, depending on which side of the Mississippi y'all are from. These agents are really good at fixing postprandial hyperglycemia as well. They have a lot of side effects, though, associated with them. Because, again, they work in the gut. They're trying to slow down the breakdown of these big sugars into smaller sugars which actually get absorbed in the gut. It slows that process down. But like we saw with orlistat, there's a lot of side effects associated with that, including flatulence, diarrhea, and cramping and the like. So we have to start very, very slow, increasing very, very judiciously. If the patient has significant renal impairment, there's at least a dosage adjustment for it. You wouldn't want to use these agents because of that inflammatory aspect and GI discomfort. You wouldn't want to use it in patients with inflammatory bowel disease, ulcerative colitis, or intestinal obstructions because they can aggravate the condition. Modest to moderate reductions in A1Cs. Not great, not as good probably as TZDs, sulfonylureas and metformin, but still an option. If you like to fart. We can edit that out, can't we? Yeah, okay. DPP4 inhibitors, the incretin system or incretin system. There's a lot of new agents within this realm now. And this is with respect to oral medications. The dipeptidylpeptidase 4 inhibitors are available now. We have actually 4 agents available now in the States as of January. Sitagliptin, the first agent, but now we have saxagliptin, linagliptin, and alogliptin in this country. And we've had vildagliptin available in Europe for quite some time, and as well as Japan. Side effects, very, very well tolerated medication. Wonderfully tolerated in the average patient in the clinical trials. The problem is really there's no dose titration per se with it. We'll come back to that concept here in a minute. There may be a risk of pancreatitis with this class. We simply don't know at this point if it's relevant or how big it is. Is it due to this or is it just with the GLP-1 agonist, which we'll talk about in a minute? We don't really know. Some patients are having anaphylaxis with the medication and angioedema. Very, very, very rare. For all intents and purposes, very well tolerated. But you don't get a lot of bang for your buck in A1C reduction with it. Depending on what clinical trial you look at, I would consider it modest reductions in A1C. Good focus on sugars after the meal. It can have an effect on fastings as well, but it's primarily having a bigger effect on postprandial sugars. There's no titration. You start on sitagliptin if you don't have renal impairment, you start at 100 milligrams. That's it. You don't get your A1C reduction you're looking at with that medication in addition to your metformin or onto something else and adding on to that. They're handy though. They're oral, once daily administration with a few side effect profile makes them attractive for some patients, particularly if their A1C is not through the roof. I don't get those kind of patients. I get the train wrecks. Bioacid sequestrant. Welcall. This actually got approved a few years back for the treatment of hyperglycemia in addition to the treatment of dyslipidemia. It has a lot of side effects associated with it you learned about when you're for the medication for the treatment of dyslipidemia. You certainly want to avoid it in patients who have elevated triglycerides, bowel obstruction, or have difficulty swallowing. And these things are the size of a small football, and you got to take like 6 of them a day. And you don't get much bang for your buck. And so, really, the trials I've seen of this agent, very small reductions in A1C overall. But if your A1C is sitting at 7.3 and you don't need much, and you don't mind swallowing a small football 6 times a day, it's a good medication. Oh, I kid the makers of alcohol. Bromocriptine. We didn't switch to neurology. We didn't switch to treatment of Parkinson's. Bromocriptine is actually also recently approved for the treatment of type 2 diabetes. Why? I have absolutely no idea, but it is. Very small reductions in A1C, wrought with a lot of side effects. I'm not saying you can't use it, but again, your A1C is 7.3 and you don't mind hypotension and syncope, it's your drug of choice. It has to be dosed first thing in the morning. Nobody really understands how it works. They come up with paragraphs of why they think it works. They haven't a clue. It's supposed to kind of reset your circadian rhythm and production of this, that, and the other thing. A host of different types of agonist and antagonist properties. They don't have a clue. I think they just noticed that was a side effect of the medication at one point in some clinical trial and decided to get it approved for type 2 diabetes. That is my personal opinion, however, so if you don't like it, email brian.irons@ttuhse.edu. All right. This is not in your handout because this just got approved. I don't want to spend too much time on it, just for your own edification, for those of you who like to practice in the area of diabetes. We have a new class of agents now approved, and we have several medications already in the hopper and asking for FDA approval. At least one already asking for FDA approval and several other in clinical trials. They are sodium glucose cotransfer 2 inhibitors. These help block that reabsorption of sugar in the kidneys, and so you excrete out more sugar into the urine. Pretty good overall reductions in A1C. They actually have some weight loss associated with it, which is good. It's oral once daily, which is good. We have no clue, however, about the long-term safety of this medication. One of the agents in this class tried to go up for approval last year and got shot down to risk of kidney issues. We don't know its place in therapy just yet. It's a little new, but it has been tried it's been well studied, just not well published, but it's been well studied in a host of different populations with type 2 diabetes on different medications. Still too new. I just kind of want to put it in here for completeness sake of we've got a new kid on the block. All right, that's it for oral treatments. But we can do injections. If patients don't fear injections, then I'd be a lousy patient with diabetes because I couldn't not inject myself with anything. I can't even poke myself with one of those little Lancet devices. I can have you do it to me, but I can't just pull that trigger and poke that thing. I just can't do it. I'd be a lousy at it. I'm sure if I developed type 1 diabetes, I would eventually figure out how to inject myself with insulin, but I'd probably have at least 3 bouts of DKA before I got there. All right, the GLP-1 are a glucagon-like peptide 1. This is another agent class in the incretin system. These agents are by injection only at this time, subcutaneous injection. Exenatide was the first agent approved several years ago. It had a twice daily formulation that you had to take within 60 minutes before your morning and evening meal. And last summer they came out with a once weekly formulation of the agent. Which is kind of nice, kind of handy. You kind of have to reconstitute it on your own at home, though. It comes with a little diluent, it comes with its own syringe, it's a kind of little tray. They're working on a pen, but I don't believe they're there yet. Supposedly in 2013 we're going to see a pen with the agent. Very good, effective medication at the treatment of hypoglycemia. The Reglatide is the competition at this point. Bunch of things in the hopper. We're talking some things like once monthly injections are potentially down the line. A lot of other once weekly formulations, once daily formulations are being studied. But right now we're down to liraglutide and exenatide. These medications help put out more insulin from the pancreas and help reduce glucagon, which is a good combination. They may promote satiety. They may help slow gastric emptying. So multifactorial, but primary mechanism is to improve insulin secretion and decrease glucagon secretion from the pancreas. None of them should be mixed with insulin. They can be used with basal insulin, but they should not be mixed. And so you got some patients who want to put everything in the same syringe. No such luck. Again, a lot of different things in the hopper. Very effective if you don't mind injections, whether it's once daily, twice daily, or once weekly. The problem is they're getting a pretty bad rap too with respect to side effect profile, particularly with respect to the risk for pancreatitis. We're just not sure. If there was a big risk, the FDA would have probably taken them off the market by now. It's kind of a controversial area based on the research at this point, surveillance. There's new surveillance now for potentially changing the cellular structure in the pancreatic duct as well. So we're not sure. But it's very effective at reducing sugars. I mean, big A1C reductions. They can cause weight loss. You know, they probably aren't going to get approved for the treatment of obesity based on the FDA cutoffs for agents in that class. But they are making the weight go in the right direction. The problem is they have a lot of nausea and vomiting associated with them, particularly the BID exenatide formulation. The once weekly formulation is a little bit better tolerated. But I mean, we're talking, you know, up to 15% of patients are actually throwing up after taking the medication. So you got to really inform patients of, you know, stop eating once you feel full. Don't continue to eat any longer because you're going to make yourself miserable. Long-term safety, we're just not sure yet. Just not sure. But very effective. You certainly want to avoid, because it can slow gastric emptying and the like, you want to avoid in patients with existing gastroparesis, history of pancreatitis. Exenatide should not be used in patients with creatinine clearances less than 30 and cautiously in patients with less than 50. Liraglutide in rodent models showed increased risk for thyroid carcinoma. We don't have any data of this in humans at this time, but if they have a history, family history or personal history of thyroid carcinoma, you want to avoid liraglutide. Busy slide on insulins. Insulins haven't changed drastically over the last few years. We have a couple new kids on the block, but not major changes here. We still categorize insulins based on how fast they act or how long they act. In the rapid-acting insulins, we still have regular insulin, NPH, which is more of an intermediate-acting insulin for how long it works. Detamir and glargine considered more longer-acting agents. It can be dosed once a day and in some cases twice a day for detamir. Don't memorize that slide for the exam. All right. Switching that and how to treat. We're going to bounce around a little bit here. Don't worry, it's all in your handout. Don't worry about the patient cases if we bounce around a little bit. For the treatment of type 1 diabetes. Here we have patient case 11. And you go, what the hell happened to patient case 8, 9, 10? We're going to come back to those. Don't worry about it. We have an A1C of 7.6 in a male patient. This could be alone. We pretty much treat the patients similarly. We may have higher doses in the treatment of type 2 diabetes with insulin than type 1, but all intents and purposes, if they're on insulin alone, that we treat them accordingly and similarly. They're on detamir, 60 units at bedtime. They're on a fixed dose of Lispro. They're not carb counting at this point. They're on a fixed dose of Lispro of 6 units before breakfast, 5 before lunch, 8 before dinner. The fasting sugars in the morning are elevated. Average about 160. I'm not having any problems with hypoglycemia. So what is the following is the best selection? Should we increase the dinner time Lispro? Should we decrease the dinner time Lispro? Should we increase the bedtime detamir or decrease the bedtime detamir? How many want to just break for lunch now? I'm getting less cards by the second out there. All right. Let me come back to this. Patient case 12. Patient wants to be started on basal bolus insulin therapy. We're going to come back to that concept here in just a moment. With type 1 diabetes, the physician wants the patient started on 0.4 units per kg per day. Which of the following would be the most appropriate basal insulin regimen? Now, I don't want to see any cards. We don't need to. We'll come back to how to solve this in a minute. But this is where we're going. Basal bolus, you can still do. A lot of you were taught before basal bolus really hit a popularity with endocrinology that you can do NPH and regular, and you can. where you did like 2/3 of your daily requirements of insulin in the morning and 1/3 in the evening, and you split those doses in the morning up 2/3, 1/3 of NPH and regular. You can still do that, and it's still quite effective. It just doesn't even come close to mimicking what the body actually does in its secretion. This looks at, after breakfast, lunch, and dinner, the insulin plasma levels that you'd see. You get a big spike after each meal. And you have a certain amount of basal insulin secretion all night long and all day long to prevent ketosis. That's what we're trying to mimic with insulins. These newer insulin analogs now is what we're trying to do is mimic what the body naturally does. We can't even get into pump therapy and those kind of things today. But basal bolus, the basal insulin is there to help prevent ketosis and control fasting sugars. And we use glargine and detamere primarily. You can use NPH, but it doesn't mimic the natural secretion very well. We use bolus insulin therapy, the term, to reduce either hyperglycemic excursions, we'll come back to correctional dosing here in a minute, or simply to most popular to prospectively try to reduce postprandial hyperglycemic excursions. And we use the rapid-acting insulins if we can for this, the glulisines, aspart, lispro. The first thing you need to do is estimate. This is all guesstimation early on. We can base everything based on fasting sugars and postprandial sugars. But early on, we weight-base the estimate, anywhere between 0.3, 0.6 units per kg per day. And you try to calculate the total daily insulin needs based on that weight. And when you do that, then you split about 50% of that total daily insulin into basal therapy and about 50% of that into bolus therapy. And you split that bolus up to breakfast, lunch, dinner. Some are proponents of just doing it one time a day first off and then start doing it 3 times a day. But for all intents and purposes, it gives us a guesstimate. Most patients with type 1 diabetes have to go through a significant amount of education on carb counting. They eat more carbs, they're going to take more insulin. They eat less carbs, they're going to take less insulin. They know exactly how much insulin to take based on what they're going to do. But this is an early estimate to get them there. And you're going to have hyperglycemic excursions. The best basal bolus therapy, patients get sick or they don't take the medication correctly or what have you, they're going to have bouts of hyperglycemia. And sliding scales have been frowned upon for a long time, depending on what camp you're in. What the term is now is to use correctional dosing. It's much more, think of it as a very patient-specific sliding scale, where you can take the total daily insulin needs of a particular patient and estimate how much 1 unit of rapid-acting insulin, how much 1 unit is going to reduce the hyperglycemia in the patient. And then you can take X number of units, 1 unit for 30 milligrams per deciliter, 2 for 60, 3 for 90, what have you, above the treatment goal. This slide goes a long way for you who have insulinophobia. There's a lot of people who don't like to dose, there's a lot of physicians who don't like to dose insulin because they're not used to it, they're not comfortable with it. The idea here is know what your fasting sugars are, know what your goals are, try to identify where the problems in the day are. Is this just a fasting problem? Is this only a problem after lunch or before dinner, or is it only a problem at bedtime? Figure out what insulin is affecting that sugar. And either change the patient's behavior if it's an isolated event, or change the insulin therapy based on the patient's sugars. That goes a long way. Again, where are the problems? What insulin is affecting that? Change that. Patient case 11 here, we have a patient with fasting sugars. We don't have any other levels, because it gets way too complex if we started doing it. But we don't have any other levels of hyperglycemia. So right now, all we know is that the fastings are too high. What's affecting the fasting? It is the basal insulin. In this case, the patient's detamere. So the answer for this one would be C, to increase the bedtime detamere from 60 to 65 units. Because that's the insulin that's affecting the problem. The problem is fasting. In that patient case 2, again, that weight-based protocol of 0.4 units per kg per day, well, the patient's 50 kilograms. That total daily insulin needs for this patient are about 20 units. And half of that should be used for the basal, so it's actually 10 units. So D would be the correct choice, because the basal insulin, glargine and detamere, not aspart. That's why C is wrong. The units are right, but the insulin formulation is wrong. All right. How do we could spend an hour and a half on treatment of type 2 diabetes recommendations alone. These have changed a little bit. We have new treatment options for hyperglycemia as of June 2012 from the American Diabetes Association and the European Society. And we're going to just briefly hit on some of the highlights. Now, this goes back to patient case 8, 9, and 10 that are earlier in your book on page 360. Newly diagnosed patient, A1C 7.8%. Not outrageously high, But some medications aren't going to get you to go. Fasting today is 186. No other chronic disease states, no cardiovascular disease. What is the best initial treatment of choice for this patient? It is just diet and exercise alone. Is it diet and exercise with metformin, or sitagliptin, or glargine? We'll come back to that for time's sake. Patient case 9. Patients had diabetes for 4 years now. They're taking metformin, 1,000 milligrams BID. Very common scenario. Now the metformin is no longer working very well. Now the patient's A1C is 7.7. What should we do? Should we continue current therapy and improve diet and activity, which they're already doing, they're very compliant with? Should we stop the metformin now and switch into something else? In this case, exenatide 5 BID. Should we add sitagliptin to the metformin, or should we add glyburide to the metformin? Again, for time's sake, we'll move on to the high-tech audience response system. Patient case 10. I have a newly diagnosed patient with an A1C of 7.5. The creatinine is quite high at 1.8. The creatinine clearance is quite low at 25. They have class 3 heart failure. They have high blood pressure. They have dyslipidemia and bilateral edema. What's the best option for this patient? Is it the DPP-4 inhibitor linagliptin, the TZD pioglitazone, the GLP-1 agonist exenatide, or metformin, the one and only biguanide? All right. The concepts now are to be more patient-focused. We'd like to think as clinical pharmacists we've always been patient-focused, and we have. But now we have guidelines that tell us we have to be patient-focused. We need to take a lot of different things into consideration when we're treating any disease state. And in type 2 diabetes, since we have so many different types of agents that we could use, we have to take a lot of things into consideration now. But we have to bring in the patient in on those discussions. We shouldn't just tell the patient, this is what you need to do. We need to put out the options out there so everybody can make an informed decision. Again, metformin is usually the drug of choice based on the guidelines. Unless they're not tolerating the medication, some patients simply can't tolerate the GI side effects and won't take it. They don't like the size of the pill or the smell of the pill. They won't take it. Or if they have significant renal impairment, you can't use it. Metformin is a great drug. It's monotherapy. The average patient, however, if they live long enough, the monotherapy will no longer control their sugars, and they're going to need other agents. The concept here is not to stop the metformin. It's probably going to have pleiotropic effects. It's probably still working. It's just not working as well as it used to. We should add medications on top of it, whether it's insulin or oral medications. So the idea here is to build, unless they're having side effects or contraindications pop up. The other concept you need to understand is the bigger they are, the harder they fall. That if your A1C is at 9%, you're going to get a bigger reduction in A1C with any one dose of any medication than you are if your A1C was 7.4%. That's across the board, whether it's any of the oral agents, period. So what do we need to take in consideration then? Metformin's there, it's not working longer. What do we do? What are we going to add to it? Well, how high is the A1C? My decision is going to be very different if my A1C is 9% or even 8% versus 7.3%. At 7.3%, you can practically pick anything. It's not going to matter. They're all going to get you at goal less than 7%. Is the problem postprandial, or is the problem just fasting, or is the problem both? Some patients only have a problem after they open their mouth and put food in it. I have patients that literally every morning their fasting sugars are wonderful. As soon as they open their mouth, their sugars go through the roof. Breakfast, lunch, dinner. They go back to sleep, boop, everything goes back down to normal. Breakfast, lunch, dinner, go back to sleep. Duct tape works really well over the mouth. What precautions, side effects, not side effects, but what precautions or contraindications exist? Do they have heart failure? They have renal impairment? They have gastroparesis? They have a history of pancreatitis? What's the overall hypoglycemic risk? They have a very strong history of significant hypoglycemic reactions. You're going to avoid sulfonylureas or insulins because their overall risk is quite high for hypoglycemia. So these other agents are very, very low risk for hypoglycemia. Is weight an issue? And weight usually is an issue, but if it went up, would that cause an undue harm to the patient? Do they want weight loss associated with the medication? And can they tolerate the side effects that go along with the medication? Is cost an issue? We talked about a lot of these newer medications. You know, newer may not be better, but newer is always going to be more expensive. Again, I wouldn't want to be able to inject myself with anything like that. I would rather take an oral medication, and most patients would. But some of the injectables are, insulin is probably the best drug to reduce sugars. There's no maximum daily dose of insulin. It's whatever doesn't cause hypoglycemia. It's a great medication. Medications. So all these things need to be taken into consideration now. So it's really difficult to say is one drug better than the other when you have to take all these things into consideration. In this case, what the initial treatment of choice with this patient was, you could select either A or B, technically. If it's a well-motivated patient and they wanted to try a 3-month trial of diet and exercise, you could do it. But the patient's not well-motivated, then really start medications and lifestyle modifications that are way, and metformin would be the initial drug of choice. Bless you. All right, for that patient's now failing metformin, they're on 1,000 milligrams BAD. It used to work, but now the A1C is 7.7. Should you improve diet and activity? Well, the guy's already compliant with diet and activity. You could, but it may not get any bang for your buck and probably not going to get you down to less than 7%. Do you stop metformin? No. Patient's not experiencing side effects. There's no contraindications listed here. You would not switch somebody from metformin to exenatide. Would you add sitagliptin then or add glyburide? Really, the decision here now is how high is the A1C? And am I worried about weight gain or am I worried about hypoglycemia? We don't have that information here in front of you. But all intents and purposes, glyburide would be a better medication than sitagliptin based on the A1C alone. That is probably going to get you at goal better than the sitagliptin. That's a pretty general statement, I know. And you can make an argument, you could do either one and see how well it works. But in this case, because the A1C is in the high 7s, glyburide is probably more likely to get you there. It just may not work long term. For this patient has creatinine clearance in the basement, less than 30. They have a creatinine of 1.8. They have heart failure, class 3. They have bilateral edema. You're going to not pick pioglitazone based on the heart failure alone. You're not going to want to do exenatide based on the renal function alone. And because of the creatinine clearance and the serum creatinine, you're not going to pick metformin because of the risk of lactic acidosis. In this case, linagliptin. Again, because the A1C is only 7.5. If it was 10.5, I'd be putting this patient on insulin. There's a lot of options that are not on the plate for this patient. But the A1C is not very elevated either. All right, winding things down in 8 minutes and 52, 51, 50 seconds. Hypoglycemia. Again, some agents have less of a risk for hypoglycemia, but once you start compounding medications and combining them, the risk goes up. So we're going to need to understand how to treat some of these acute complications. Really, how you're going to treat hypoglycemia is going to be dependent on how low it is. If the plasma glucose level is, the usual criteria, for hypoglycemia is with or without symptoms, and the plasma glucose level is less than 70. If it's fairly mild or moderate, the patient's still cognitively with it and can do something, they usually recommend a 15 to 20 gram oral glucose or some kind of equivalent, whether it's out of juice or candy or what have you. Juices are going to work faster than in some candies. If it's severe, the patient's out of it, loved ones, if that's the case, and the patient's having frequent bouts of real significant hypoglycemia with impairment, the loved one should know how to use a glucagon injection. Worst case scenario, then with EMS, and like to use IV dextrose if it's really severe. So oral glucose if it's relatively mild, IV glucose if dextrose if it's significant, and glucagon as well. DKA, or diabetic ketoacidosis. True medical emergency. A lot of patients with type 1 diabetes actually present. They never knew they had diabetes before. They actually present to DKA. This is where you have very significantly elevated blood glucose levels, a certain amount of ketoacidosis going on, and patients often present with dehydration. You can get a lot of the signs and symptoms are listed here. You can get that fruity breath smell, the acetone smell on the breath. You can get urine and serum ketone levels. Sometimes they'll be low in sodium, high in potassium. They don't necessarily have to be high in potassium. You can have low potassium as well. They may have tachycardia, a lot of very nonspecific GI complaints that the patients may get. Usually, it's going to be caused by some kind of acute trauma or illness, and or the patient simply not taking their insulin correctly. You usually think about DKA and type 1 diabetes. Yeah, they are a very high risk for it if they don't take their insulin correctly, or they run into a problem with sick days and those kind of things. But patients with type 2 diabetes can get DKA as well. Great statement by the ADA out there. Last recommendations were in 2009. Great source of information. You really want more information about how to treat DKA. The reference is there in your handout and on the slide. Wonderful statement. Fix the underlying cause. If you know it's an infection, treat the infection. If it's poor compliance or other, you got to fix the behavior of the patient. It is not about normalizing glucose levels to 70 to 130. Yeah, we want to get the hyperglycemia down from here to here, but we don't want to necessarily normalize it. We'll come back to the goals here in a moment. Because most patients who present with dehydration, you want to have a certain amount of fluid replacement. We do want to get the sugars down, and we're talking IV. There are some subcutaneous trials out there in DKA as well. For the most part, that we're talking infusions of insulin with a bolus of 0.1 units per kg and the drip rate of 0.1 units per kg per hour. Patients don't respond after an hour or two, you can double the drip rate. If the patient has hypokalemia on presentation, because insulin, once you inject it, can cause potassium to go from, drive it into the cells, you can make hypokalemia worse. So if they do have hypokalemia, you're going to want to fix that before you initiate the insulin infusion. How much is really dependent on the baseline potassium, but the recommendations in their statement and actually very, very well thought out. Our treatment goals, again, not for 7130, but you can consider the treatment a fairly good success if the sugars are at least less than 200, the pH, and at least two of the other following, that the pH is now is risen up to at least 7.3. The bicarbonate is back up to closer to normal at 15, and you have a reduced anion gap. At that point, you can probably get them off the infusion of insulin and convert them to subcutaneous insulin. Oh, about a 20-page handout wrapped into 2 or 3 slides. What do you know? All right. We need to do a better job in patients in this country at screening for the complications associated with disease. If it's an epidemic of type 2 diabetes, we need to be doing screening for the complications that much better. Bless you again. Type 2 diabetes, they may have diabetes for a long time. Some patients may have it for 5-10 years and don't even know it. They've had hyperglycemia that long, but they didn't actually get diagnosed because they weren't screened properly. So for patients with type 2 diabetes, to at least screen for some of these complications, whether we're talking about retinopathy, nephropathy, neuropathy, you want to screen them right away at diagnosis. The average patient with type 1 diabetes is going to present fairly fast. The hyperglycemias come on pretty fast, so you don't need to start screening them for the complications associated with the disease until about 5 years after diagnosis. And once you get to that point, then we start screening everybody once a year. Urine, albumin, to creatinine, ophthalmic examinations for retinopathy, monofilament studies and things like that in the feet for signs and symptoms of neuropathies. This has changed as of 2013. For a while there, it started getting kind of weird of, okay, we had recommendations of what is microalbuminuria, what is full-blown proteinuria or macroalbuminuria. They made it a lot more simple. Simpler? Yeah, more simple, simpler. Right now, basically, you get a urine spot, urine collection for albumin to creatinine. You do want to get, some people just get the urine albumin, you want the ratio. Normal is considered less than 30, that hasn't changed. But what has changed is we don't have microalbuminuria anymore, we don't have proteinuria anymore. You'll still see it a lot in the literature of what's been studied with what and how. But now it makes it just easy. Now if it's 30 or greater, it is simply increased urinary albumin excretion. Which makes it like, because really it didn't matter how we treated it. For a while there it was, okay, if you have type 1 diabetes and you have any degree of albumin in your urine, you should be on an ACE inhibitor. But if you had type 2 diabetes with microalbuminuria, you could pick an ACE or an ARB. Or if you had type 2 diabetes with renal impairment, with hypertension, you'd have to pick an ARB. It got very confusing. And they kind of took that away and said any, type 1 or type 2 with any increased urine albumin excretion, you'd use an ACE or an ARB as the treatment of choice in those patients for good reasons. Very, very well studied. But now we don't have to deliver whether it's in micro or macroalbuminuria. Just basically now, the 2012 plus guidelines, ACE and ARB, but now we have the recommendations are anybody with increased urinary albumin excretion should be on an ACE inhibitor or an ARB. Now some would argue whether they have hypertension or not as well. I see this a lot too, people coming in with some degree of neuropathies, whether it's just kind of a tingling or numbness at this point. Anybody who walks in with tingling and numbness in the PCP's office these days seems to get put on gabapentin. Really when we're talking about what's been studied with these agents, whether we're talking about tricyclic antidepressants, TCAs, whether we're talking about anticonvulsants that have been commonly used for neuropathy, it's neuropathic pain that's what's been studied. Really lancinating sharp pains that the patients can get from long-term hyperglycemia. TCAs are wonderful medications from an efficacy standpoint. The problem is they have lots of anticholinergic side effects and are not well tolerated. And usually the doses of these medications are a lot lower than what you would actually use in the treatment of depression, where they're not used that much commonly anymore either from a side effect profile. But you can use gabapentin, lamotrigine, pregabalin are all been looked at least. Some of them are approved, some of them are not, but at least been looked at and studied in neuropathic pain. They're probably not any more efficacious per se than TCAs, but they're certainly better tolerated. Duloxetine is also approved. You can use tramadol, the combination of tramadol, acetaminophen. So basically what works in patients. But don't expect some patients to go from a pain scale of 7 or 8 down to 0. They simply don't work that well. You may go from a 7 to a 4, and that's a good thing if you live in pain, but they're still going to have some degree of pain in the average patient. Cardiovascular disease, big time. Again, the recommendations for goal blood pressure should be less than 140/80 in general. I'm still shooting for 130/80 in most of my patients if, again, they have at least 10-year plus life expectancy, and I can get them there with minimal medications. Ideally, that regimen should contain an ACE inhibitor or an ARB. Ideally. And now the recommendations as of 2012 have changed a little bit too, based on one trial at that. Take at least one of the antihypertensives at night. That kind of snuck in the ADA guidelines last year in 2012. Cholesterol therapy, regardless of baseline LDL, statin therapy is recommended for patients if they have established heart disease, for sure, if they're greater than 40 with other cardiovascular risk factors. If the patients don't, we're trying to shoot for less than 100 with these patients. We don't necessarily need to reach for fibrates. We don't necessarily need to reach for Zetia and the like. Statins really have been studied for primary and secondary prevention in this patient population. If they don't, cover that red light up, if they don't respond adequately, can't get them to less than 100, as long as you get at least a 30-40% reduction in LDL, it's probably pretty good, because that's what really they found in the clinical trials. Aspirin therapy. This has changed a little bit in the last few years as well, because for the longest time we were just throwing aspirin at practically anybody, regardless of their overall cardiovascular risk. We don't have a lot of great data to support antiplatelet therapy in patients with type 2 diabetes as primary prevention. Secondary prevention, yeah. You already had a history of heart attack or some established form of CAD, you should be on aspirin therapy. However, if you haven't, you should have at least a 10% more risk, a Framingham risk score risk of an event within the next 10 years. So we usually do the Framingham risk score on patients, and that risk for having a cardiovascular event in the next 10 years is 10% or greater. The recommendations now are for antiplatelet therapy. If it's less than 10%, there may not be any more benefit, and there may be actually higher risk for gastrointestinal problems. They can't tolerate aspirin, Bladix. All right. 90 minutes to cover everything in endocrinology for you. I know we had to fly through a lot of things for you. This is us in Lambeau Field last year. I'm a diehard Packer fan. You can spot me, I'm the idiot with the video camera going, woo! It was the first day they put on the Jumbotron. All right, I'll take any questions up here because I know you guys want to do lunch. I'm more than happy to stick around for as many questions you guys have here. And I hope you have the best of luck come October when you take your examination. Thank you very much.